Hello and welcome back to the NWR Virtual Healthcare Conference. My name's Matt Wright. Next up this morning, we have CurveBeam AI, which is one of the private companies we have presenting. Joining us is the CEO and Managing Director, Greg Brown. Before we get started, just another reminder, if anyone has any questions, please feel free to type them in using the Q&A function within Zoom. Greg, I'll now hand it over to you. Please go ahead.
Thanks, Matt, and thanks for this opportunity to present today at the NWR Healthcare Conference. If we could just move forward, I'll just bring your attention to the disclaimer slide, and then the next slide, please, Matt. Next slide. So CurveBeam right now is in an exciting part of its growth phase with the launch of its flagship product, the HighRise. Now, we have a portfolio of natural weight-bearing CTs. This is functional CT that's designed to better diagnose and to plan surgeries for total joint replacements and or corrective surgeries, whether it's involving plating or screws for fusion. So this whole new field of weight-bearing CT today, we've got a unique position in being able to lead a lot of these applications. And right now, strategically, it's all about how quickly we can establish our footprint from our platforms. Now, every time we sell an instrument, and a HighRise is around 500,000 Australian dollars, we're looking at about a 50% gross profit on the system. However, we have a range of AI solutions that we can lay down upon that strategic footprint that then allows us to target around a $200,000 to $300,000 annuity stream, and that's targeting a profitability of greater than 90%. So it's really all about how quickly we can place our strategic footprint into the market and leverage our AI solutions off that through our SaaS models. We're quite advanced on the regulatory front. All of our key platforms have FDA, TGA, and CE marked. Our OSView is under FDA review, and it was given a breakthrough device designation for being able to aid in the better assessment of fracture risk. We also have two other SaaS solutions that are close to FDA submission, and I'll talk more to those later. We're also taking advantage of existing reimbursement under those CPT codes for CT. One is a specific coverage, which means it's medically necessary, and the other is a non-specific coverage, but a coverage with CPT coding and payment in place, and just needs to meet the requirement of reasonable and necessary for that particular patient under those national coverage determinations. So we're well advanced on those three key pillars. We have this first to market solution in this functional CT, and we have global partnerships now that we can leverage not only in the validation of our technology and delivering the evidence-based medicine that we need, but also in the co-marketing and co-sales opportunities in placing these devices. So as we go to build this franchise that we look to build over a period of time, we are defending that franchise as best we can with IP, always being on the forefront in technology solutions, and of course, the clinical validation and having significant validation around those products. Next slide, thanks. So this is the product range. I draw your attention to the two products on the left, the InReach and the InReach HRPQCT. So the InReach is FDA CE marked at TGA. It is a product for the hand surgeon or the wrist elbow surgeons. It's a point of care device that can do CT imaging of the hand, wrist, and elbow. It's ideal for fracture management, osteoarthritis diagnosis. There's a range of applications for the InReach for the surgeons that specialize in those anatomical areas. The InReach HRPQCT is a high resolution peripheral quantitative CT. So if we look at the InReach being a 300 micron resolution, we are looking at 80 micron with the HRPQCT. So a very high resolution device. Both of these devices give a radiation dose of 3 to 5 microsieverts, so it's negligible radiation. Now from that scan, we can look to do fragility fracture, large population-based screening solutions. It's a 1.5 minute reading, so you can process patients very quickly on that device, and it's looking at microstructure, not bone density, as the necessary cause of fragility risk and fracture risk. The PEDCAT Premium, which really focuses on the foot, ankle, and knee, and then of course our flagship, the HighRise. This is a product that can do both weight-bearing CT, as in the center photograph, but also supine positioning, so you can see non-weight-bearing and weight-bearing, which is very important from a diagnostic perspective, especially around foot and ankle knee conditions where you may want to look at syndosmosis diagnosis, Lafranc diagnosis, bunion correction surgery requirements and planning, osteoarthritis diagnosis. There's a whole range of diagnostic applications and surgical planning applications which benefits from this weight-bearing and non-weight-bearing CT in a point-of-care facility. The HighRise also can flip its gantry to do the hand, wrist, and elbow. Next slide, thanks. So the HighRise for us, being our third generation technology, really delivers a unique opportunity in advancing surgical care around, especially around total joint replacement. So, 90% of the people who will go to their orthopedic surgeon for restoration of function, it's usually due to advanced osteoarthritis. But there's a comorbidity issue where a lot of these patients, from 50 years on, will have a comorbidity with osteoporosis or bone fragility. And that's one of the highest risk factors for an implant failing and needing revision surgery. And a lot of those revisions are due to aseptic loosening, and that's where the bone doesn't fully integrate around the implant. Now that can be due to osteolysis, that can be also due to just less and less building blocks as the bone is remodeling. But what is important is that if you can identify this early and pre-treat, then you can reduce, hopefully, the number of revision surgeries. And I'll go into that in a bit more depth later. So we see that this is a very opportunistic means of screening for bone fragility as part of the surgical planning for a total joint replacement, so as to reduce your risk not only in the adverse event of aseptic loosening and the need for revision surgery on that implant 2 to 5 years down the path, but also in preventing fractures both on the table during the procedure and post the procedure. Next slide. So as part of this SaaS overlay onto our strategic platforms, one of the SaaS, the InReach HRPQCT, this is the population screening device that's looking to better identify fragility fracture before a first fracture and looking to target therapeutics, which are widely available today, are safe and effective in reducing the number of these fragility fractures. And that will offer the one SaaS solution of microstructure. But the HighRise is unique. It's unique in several ways. Number one, we're looking to better balance the skeleton through any total joint replacement in the lower limbs. And then from that, while they better plan for that surgery and that weight distribution through that implant, what they don't want is to be 1 or 2 inches short on one side, because then you can create an issue on the contralateral limb and potentially create osteoarthritis in that limb. So it's very important that with the skeleton underweight, that you're planning this and getting your cut guides and everything correct to prevent that, so that you keep a well distributed weight through the skeleton. Now, beyond that, that scan is taken for diagnosing the condition of osteoarthritis. It is then going to be used for the surgical planning for the restoration of function. And as part of that, once that scan is taken, we can then offer a bone mineral density result, which in about 70 to 80% of the cases will not be assessing the fragility to the level that the surgeon's going to want to see it. They're going to want to be able to triage all their osteopenic and normal patients, and that's where they will be able to do microstructure at the ankle or off the one result as a second billing off the one scan, the scan for both diagnosis and surgical planning, and the second billing, once that is a pre-existing scan, for looking at that bone fragility and instigating a strategic plan for their surgery approach that also deals with the bone fragility. We also have AI solutions for especially foot and ankle. We also will advance this into the hip and knee, where it's a totally automated bone separation and segmentation technology with an autometric measurement between anatomical points and angles to help in the doctor diagnosing some of these specific conditions. Next slide. So today we have around about 160 units placed globally, mainly in US and Europe. We're now, while we're showing 3 here, it's now close to 6 devices in Australia. We have our corporate office in Melbourne, Australia, and we have our headquarters, operational headquarters in Hatfield, Pennsylvania. And we are utilizing both a hybrid of direct sales resources in key markets like the US, Germany, UK, and distributors. And today we have that hybrid model outside of the US as well as inside the US with our recently announced Stryker agreement. Next slide. So Stryker Foot and Ankle Division recently announced their co-promotion and distribution agreement around the HighRise. And this has been set up so that patient can walk straight on board, take their measurement, they press a button, the data sets that are all validated then go straight into their prophecy system for their cut guides for doing their intervention around the restoration of function. So it offers a very unique solution in delivering functional CT and planning off that functional CT, and it can go directly into these next generation robotic aided surgical systems. Now, this relationship is just the foot and ankle today, and we are looking to work with their knee and hip division to also validate the data sets or protocols required for their robotic system as well. Now, this Stryker relationship still allows us to work with other vendors, and we have 2 other validated vendors with protocols off our device, but we can only sell the instrument directly to the customer in those settings. Stryker has the unique right to buy this device and place it directly with the customer. So it's quite an exciting validation of our technology. It's the biggest player in this orthopedics field. And we really like having this opportunity with Stryker, and we're looking to expand this relationship over time, both to knee and hip, and also potentially geographically. Next slide. Next slide. So when you look at the HighRise and the view that it gives, what we feel is the future around weight bearing is this unique view of hip to foot. Whether you're doing an ankle replacement, a knee replacement, or a hip replacement, is that full alignment through the skeleton. That how does the weight sit from the implant you've put in? Is it, you want to make sure that weight distribution is aligned correctly and that you're not creating a secondary issue. So our devices give you the ability to do just the region specifically, or you can do the full scan hip to foot and make sure that your alignments throughout the skeleton are optimized so that you have that balance and that you're not creating a potential contralateral issue. So it's very unique to our HighRise. And don't forget, we can offer that both in a supine position, so non-weight bearing, and weight bearing. And diagnostically, that has a lot of value. Next slide, please. So here's some examples. Here is a supine on the left CT scan. What you'll see is that it looks okay. It's not that bad. But as soon as you put that underweight, immediately you can see the whole talus is moved. You see directly where the impingement is occurring. So this is a foot and ankle, but it really unlocks a lot of diagnostic information that is not picked up when a patient is lying down. So functional CT is becoming a really indispensable tool in improving this diagnosis, but also surgical planning. On the next set of slides, there's a CT scan elderly lady. She had a partial knee replacement. Here's an example of where weight bearing wasn't used effectively. They put in a partial implant. Once they come underweight, this patient had considerable pain. And when you look at that joint, it looks okay. The spaces may be a little bit distorted, but there shouldn't be an issue in that joint. As soon as it's underweight, you see how the whole joint moves at an angle, and you create an impingement at where the triangle is showing. You create the bone impingement where the pain is, and you see how the splacer is totally now out of place. So these are some of the benefits that if you do the surgical planning underweight, you're less likely to see some of these events that can end up in a revision surgery straight after the initial surgery. Next slide. We have numerous key recognised institutional users today. Mayo Clinic has 3, HSS has 3 units, Penn, Rush, Duke. Duke will have 2 devices. So we're getting a very good clinical base of KOLs. Next slide. In our manufacturing plant in Pennsylvania, we've set up with 2 cells for manufacturing HighRise today, and 1 cell can produce 1 HighRise every 4 days. And we have 2 cells that are up and running. We can expand that to 20, to 10 or 20 cells if we need. We can also do 2 shifts. But right now, even with 2 cells, that's giving us 10 devices per month. But we can easily phase up, if needed, the number of cells and the number of shifts. We meet all the required manufacturing accreditations. We've just been recommended for our MDR as well for CE. So we're well placed, and it's US-based manufacturing in our key market. So we're well placed to also support in the field with application specialists, technical service, and sales support. Next slide. So moving on to bone fragility. On this bone, well, today, people hear of bone density for screening. It's 2 energies of X-ray, it's 2 scans over the body, and you look at 1 X-ray, 1 energy is absorbed by the hard tissue, 1 by the soft tissue, and you look at a silhouette of the bone and compare that to a normal population. But bone density has proven to be, about 70 to 80% of fragility fractures don't lie within BMD-defined osteoporosis. So we're moving to microstructure. And these 3 micrographs on the right shows how all 3 patients have a normal BMD. They can all still cast a shadow, but the bone remodeling that is occurring in each of those patients is creating significant fragility in the 70-year-old, 90-year-old, not seen in the 27-year-old, yet their densities are equivalent. So we're all about microstructure as the necessary cause of fragility and improving your ability to identify that fragility before a fragility fracture or before an implant so that you can prevent the risk of revision surgery. Next slide, please. So it's a global problem, and today we have a range of safe and effective therapies for being able to better target therapy to prevent a first fracture. The issue, though, is access. 30% of females are scanned before a first fracture. Less than 15% of men are scanned before a first fracture. So access, there's waiting lists on BMD often is a big complaint that we hear in the US. And that's because, the device is capable of maybe 2 patients an hour. Our device is 1.5 minutes per patient. So once that scan is taken, you can then bring in your next patient. So it has a much faster throughput. It also is point of care with a small footprint and negligible radiation, so it can be run in the clinics and allows you not only to expand your capability of screening your population, but to manage those patients as well. Manage them for compliance, that they're on their therapy and staying on their therapy. So we are really looking at microstructure as a major way of improving a first fracture prevention strategy. Next slide. And this is all done on a fully automated AI platform. So the scan can be taken at the ankle or at the wrist. It then separates out the tissue, realigns the bones, finds the region of interest, and then breaks out that cortical bone and transitional zone and trabecular bone to calculate the fracture risk based on the bone microstructure. Next slide. Next slide. So this is our next generation weight-bearing CT, and these are our targeted specifications. You'll note that we're taking the HighRise design and applying a telescopic extension to be able to deliver a CT scan in a point of care setting right up to the neck. So you will now get weight bearing in the shoulder, neck and spine, hip, knee, and foot and ankle. Now, the spine on its own is it's a massive market. It's far larger than the lower extremities, far larger than shoulder. But the spine market on its own is such a large market. It's really important for how they fuse the spine, that they get those angles right, and that they've got it underweight. So we see this as a major expansion, but not at all sabotaging our lower extremity, because if you're a hip specialist or a knee specialist, or a foot and ankle, you only need the HighRise. But for the spine and shoulder specialists, they will need the SkyRise. Now, if they happen to have a hip and spine guy in their group of surgeons, if they're in a group practice, then they can do this device. But more often than not, you find the lower extremities congregate in similar practices. Next slide. Yeah, we've laid down an awful lot on the IP. We're really wanting to protect this franchise, especially around the AI annuity that we look to build on that platform. And so we're very active, and we continue to be very active in making sure that we're putting down IP that is utilizing our strengths in weight-bearing CT and AI and deep learning AI. So on that note, I'll bring it to a conclusion, and we can open it up for questions, Matt. Oh, and our board. Oh, sorry. There was one slide left. Yeah, Rob Lilly is our chairman. Arun Singh is my business partner. He has, he was one of the pioneers in applying cone beam CT in dental maxillofacial applications. And he was very successful in placing 9,000 placements of that device in dental offices. So he brought an expertise of point of care CT imaging, high resolution, clear images, point of care, low radiation. And so this has now been applied to these medical applications that we have and that we need for our deep learning AI. So it's a huge asset to the company. And it's great, that Arun is not only an executive director, but, very much active in our in our technology advancement and operations in the US. We have Hashan De Silva and David Seaman also on our board. So on that note, I might open it up to questions, Matt.
Great, thanks very much for that, Greg. As you've alluded to there, we will take questions. So if anyone has anyone in the audience wants to ask one, please use the Q&A panel within Zoom. I'll start off with Greg. Are you proposing for the HighRise as a platform for population-based screening, or is that for InReach, and how will they differ?
So if you could just come back to that portfolio slide where we show all the platforms, I'll just explain that, Matt. So now HighRise, because it's a CT scan of the hip, will never be a primary screening tool. It is an opportunistic screening tool where the image was taken for the requirement of a surgical diagnosis of osteoarthritis in the joint and the surgical plan. Once that CT becomes pre-existing, we can then use a BMD CT and our SFS on that opportunistic market. Now, by 2030, that represents around 3 million implants annually in the lower extremity. So it's a significant opportunity for us. So it's really that opportunistic market where the surgeon needs to manage the comorbidities of osteoporosis and osteoarthritis together to improve outcomes. Now, the InReach is specifically designed to be that large population screening device, and it's just using microstructure, and it enables you to put through a lot of patients in a single site very quickly. There's no trained operator needed for it. So the InReach is our population screening device. The HighRise is really that opportunistic, where there's total joint replacement surgery being planned, that we can offer a opportunistic screen for this fragility and an intervention around that.
Great. And if the HighRise can do the fragility testing opportunistically as part of the total joint replacement surgery plan, how will the result change the surgery plan?
That's a good question, Matt. Look, today, only about 15% of these patients will get a BMD. And often it's due to the fact that the BMD comes back osteopenia or normal. It doesn't match up with the doctor's suspicion of what he's seeing in the joint or around the bones. So we feel that what we can offer with our microstructure and our BMD together for them as part of that surgical planning, they can triage their osteopenic patients straight away. Now, if they see that there's significant microstructural fragility in those osteopenic or normal patients, they can start an anti-resorptive as part of the surgical plan and then go to a cemented joint. And so this can have a major impact in changing their strategy in planning the surgery. And there was a recent publication, it's a randomized control trial that came out of the UK, and it showed a 50% reduction in hip revision surgery due to a reduction in aseptic loosening, so prevention of osteolysis, through the use of a commonly used anti-resorptive drug that's on our PBS in Australia as well. And as that was administered before, it helped prevent that loss of osteointegration over time. So it was about a 50% reduction in hip revision surgeries. So that's a big deal. And it just really points to why this information needs to be in the hands of an orthopedic surgeon, because if they can manage both the comorbidities together, they can not only improve those revision rates on their patients, but they can also prevent fragility fractures and first fragility fractures, possibly the one that could have occurred on the table or post the implant, and or down the pike where they might have a fall. Having had that treatment and continuing that treatment through that diagnosis can have a very long-term improvement on two major clinical endpoints in an aging population: revision surgery and fragility fracture.
Thanks, Greg. And just one final one. I know the company wrapped up a capital raising not too long ago. Can you just give us the sort of highlights on that one as well?
Yes, we went out to target 15 million. We were able to oversubscribe the round and were able to raise 25 million. And that has really helped us in preparing for our launch and supporting the Striker program, our SkyRise development, and of also bringing through our SaaS annuity stream as quickly as we can, because once we've got that strategic footprint out there, that investment goes a long way in helping us to deliver those SaaS solutions, which is where we drive most of our profitability and I think value longer term.
Great. Well, thanks very much for the presentation today, Greg. We'll leave it there. Thanks for your time, and we'll move on to, no problem. We'll move on to the next session in about next 5 or 10 minutes, which is from Aroa Biosurgery. So I hope everyone can join that one. Thank you.
Thanks, everybody.